ॐ सहनाववतु सहनौ भुनक्तु सह वीर्यं कर्वावहै तेजस्विनावदितमस्तु मा विद्विषावहै ॐ शान्तिः शान्तिः शान्तिः. Dear students, today we are going to discuss the fracture of distal femur. Now the distal part of the femur encompasses the lower one-third. It varies between 7.6 centimeters and 15 centimeters of the distal femur. The supracondylar area is a transition zone between the distal diaphysis and the femoral articular surface. The distal femur is subjected to the quadriceps force anteriorly and the flexion force of gastrocnemius posteriorly. The fractures of the distal femur could be classified into 1. The supracondylar fractures, intercondylar fractures, then unicondylar fractures, and lastly the comminuted fractures. The distal femur fracture accounts for 7% of all the femoral fractures and consists of supracondylar fractures and intercondylar fractures mainly. Let us focus more on the supracondylar fracture femur today. The supracondylar region extends from the femoral condyles to the junction of metaphysis with the femoral shaft. The distal fragment is displaced and angulated posteriorly due to the pull of the gastrocnemius muscle. As you can see in this particular diagram, on the second diagram, the 3D reconstruction where the distal fragment is flexed posteriorly. Now the mechanism of injury, it is due to the severe valgus or the varus forces with the axial loading and rotation due to the road traffic accidents, falls, etc. Classification of these fractures. NIRS has classified this into 3 major groups. He has described the 3 groups like, as you see in this particular diagram, the A shows the undisplaced fractures, B and C shows the displaced fractures, and D shows the comminuted fracture. So the 3 major groups: undisplaced, displaced, and comminuted. And the displaced fractures may be displaced either medially or laterally. Mueller's classification has been accepted by AO people, and again the same 3 major types are described: type A, type B, type C. And type A are mainly the extra-articular fracture. You look at the upper level, the upper row, that is the type A. All fracture lines are running extra-articularly. Type B is a unicondylar fracture, and type C is a bicondylar fracture. Now each type A, B, and C, they are further subdivided into 1 to 3 depending upon the severity of the comminution. The OTA classification of supracondylar fracture femur again is very similar, where type A is extra-articular, type B is partly articular or unicondylar, type C is total articular or bicondylar. Now type A, first is simple, A1, A2 is metaphyseal base, and A3 metaphyseal comminution. Whereas in type B, B1 is a fracture of lateral condyle, B2 is a fracture of medial condyle, and B3 is a frontal fracture. We also call it as the Hoffa's fracture. You can see the B3 in this particular diagram. And then type C, the articular and the metaphyseal simple. Look at this C1, and C2 is the articular simple and metaphyseal comminution, and C3 total comminution. Coming to the clinical features of supracondylar fractures, it consists of the usual features of fracture: pain, deformity, and abnormal mobility. But what is specific to this fracture is the flexion deformity caused by the pull of the gastrocnemius, You can see in this particular diagram how the distal fragment is flexed. Hemarthrosis is commonly seen, especially with the fractures extending into the joint. Radiographs helps to study the fracture pattern more accurately, and routine AP and lateral, and then sometimes the oblique 45-degree oblique views are also required. Arteriography, this should be performed in suspected vascular damage or in associated dislocation of the knee joint. Coming to the treatment part of the supracondylar fracture, the treatment usually consists of the conservative method, traction, and operative methods. So, as far as the conservative method is concerned, nowadays this has a limited role and is usually useful in impacted and undisplaced fractures only. So, in the former, that is impacted fractures, a long leg or a spica cast is sufficient, as shown in this particular figure. Whereas in the latter case, that is the undisplaced fracture but not impacted, a long aboni cast after the initial period of skin traction or skeletal traction is all that is required. The traction methods, the choice is mainly the skeletal traction, and the two methods are described here. The first method, the upper tibial traction. As you can see in this particular diagram, how the traction is applied using the tibial pin, and here the skeletal traction is through the upper end of the tibia. The initial weight is used around 15 to 20 pounds and is subsequently reduced. Now you can see the fracture is supported well with the help of pillows. Now the traction is given for a period of 8 to 12 weeks, and the patient is later put on the cast bracing. Now, to prevent the knee stiffness from developing, the patient is encouraged to carry out the knee movements during the traction itself. Now, there is another method. This is a two-pin traction method. Now, you can see in this particular diagram, the traction is added through the distal femur apart from the traction given through the upper end of the tibia. And this helps in accurate reduction of the fracture and maintains the reduction so obtained. The disadvantage of this technique is it is cumbersome and may cause neurovascular compression in and around the knee. Then remains the operative methods. Now this consists of open reduction and internal fixation, and it is preferred as the closed reduction is associated with troublesome complications like limited knee motions, residual varus, and internal rotation deformities. The advantage of the open reduction are early mobilization of the knee joint and an accurate reduction and rigid fixation, as you can see in those particular x-rays here. Now the fixation methods, intramedullary fixation can be done, and it includes the rush pins, the ender nails, the medullary nails, the split nails, static locking nail, etc. are some of the commonly used medullary fixation methods. Now these offer all these implants, they offer biological fixation, but the fixation offered is less stable. So there is another method, the blade plate fixation. Now this includes the AO plates, Elliott or the Jewett plates comprise the blade fixation method, but they are technically very demanding. It gives the dynamic condylar screw. Now it gives a good fixation and is a better option, but it requires minimum of 4 centimeters of uncomminuted bone over the intercondylar notch for the effective fixation. That is well shown in the second diagram. You can just observe how you require the 4 centimeter of uncomminuted portion of in the distal fragment. The Buttress plate. Now the Buttress plate is recommended in highly comminuted fractures. The condylar locking plates with the special screws that helps the plate to be locked to the bone are now being increasingly used and are giving good results. They offer good fixation and prevent the varus angulation because they are already pre-bent or pre-contoured, and that is why the varus angulation is prevented. Now external fixation can also be used as a method of fixation. Now they are being used either for a temporary or permanent fixation of these fractures in open distal fracture, femoral fractures, and if they are associated with the vascular injuries. Now as you can see, the first picture is showing an example of a hybrid external fixator, whereas in the second diagram what we are seeing, we call it as a spanning external fixator, usually given for temporarily till the time the wound is healed, and then it can be converted into internal fixation. LISS, LISS, less invasive stabilization system. Now this has a learning curve and gives good results in the trained hands. You can see there is a plate which can be inserted with minimal incision as shown in the fourth diagram, and that plate is having an associated jig using which you can insert the screws directly percutaneously. This has less morbidity and offers all advantages of minimally invasive procedure. As however I told you, the learning curve is high. Then double plate fixation. Now this is preferred in very low and comminuted distal femoral fractures. Here the lateral plating alone may not provide the necessary fixation, and hence the medial plate needs to be applied. Then comes the minimal invasive surgeries. The minimal invasive surgeries involving the DCS and the condylar plate fixation is being increasingly tried for the obvious benefit. Then Trigen nails, the third generation knee nails. Now this picture shows the supracondylar nail, third generation. It is inserted in a retrograde fashion through the intercondylar notch, and it is a titanium nail and has two holes for the oblique screws and one for the transverse screw at the insertion end. And at the opposite end, locking end, the two holes are present in anteroposterior plane and two holes in the lateral plane. The results are very encouraging. As you can see in this particular X-ray, how beautifully the supracondylar fracture femur has been fixed using the intercondylar nail, the supracondylar nail. Coming to the complications commonly encountered in the supracondylar fractures are the delayed union, first important, second malunion, third non-union. Now you can see in this X-ray the patient after fixation he felt secured and he tried to put he had wet bearing before the fracture united, and it has resulted into the important complication, the implant failure. Now as all implants are inserted from the lateral aspect, the injury to the popliteal vessels and common peroneal nerves are also common, and of course the injury being near the knee joint, the knee stiffness, the deep vein thrombosis, infection and implant failure, etc. all come under the complications of the supracondylar fracture femur. Now do you know why the fractures of distal femur are difficult to manage? So there are 4 points. The first point is they are frequently comminuted, as you can see in this 3D reconstruction. And second, due to the distractive muscle forces, anteriorly the quadriceps and posteriorly the gastrocnemius muscle. Then third, due to the proximity to the knee joint, resulting into the stiffness. And fourth, due to the associated trauma in young, because often it is a high speed velocity injury, high velocity injury in youngs, and due to medical problems in the old. So the old patients, they may have a low velocity injury, however at that particular age there are a lot of medical problems associated, and that's why it is the most difficult fractures to manage. And before we end here, I want to talk to you about one more important topic: happy key to lose weight. Dear students, one of the commonest problem we are facing in our routine clinical practice is of obesity. Eat less and exercise more formula for treating obesity has been proved to be the failed formula. Of late, I have been working on the latest, most scientific, evidence-based concept of weight loss, happy key. You may find few videos on this topic as well on my YouTube channel. The obesity among the medical student is at its peak nowadays. Due to obesity, not only they are bullied, but most of them also lose their self-confidence, resulting in deteriorating performance in academics. For all of them, this online video course, of course it's a paid course, will be most valuable. If interested, you may visit my Facebook page, The Happy Key, or website www.drorthosudhir.com. For details of this course, I recommend you all to watch my above mentioned video on YouTube completely. You can enroll for the course by paying the fees as suggested in that particular video. You may forward that video to others as well. YouTube link is given here. Just find that link. And remember, my mission is to help more than 10 lakh persons to lose weight and get lifetime freedom from their obesity without dieting and exercising using this happy key technique. Let us all come together to create a healthy and fit India. Please like my channel, subscribe it now, and do recommend it to all your colleagues from other medical colleges. Please help me to help medical students all over the country. Your recommendation matters a lot for me. Thank you for your subscription. If not visited yet, please do visit my YouTube channel now. Like it, share it, and subscribe it. Thank you.